Hi, good day everyone. In today's lecture, we will comprehensively discuss about vesicoureteric reflux, its anatomy, pathophysiology, grading, clinical presentation, complications, and modern management strategies based on standard urology guidelines. So, what is vesicoureteric reflux? Vesicoureteric reflux is defined as the abnormal backward flow of urine from the bladder into the ureter and sometimes up to the renal pelvis. It occurs due to failure of the uretrovesical junction to function as a one-way valve, and it can be of two types, primary and secondary vesicoureteric reflux. It is primarily a pediatric condition often found in up to half of children presenting with febrile UTIs. There is a strong genetic component, and siblings of affected children have a higher risk. The anti-reflex mechanism depends on an adequate length of intravesical ureter. Normally, the ureter passes obliquely through the bladder wall, creating a flap valve mechanism. When bladder pressure rises during voiding, the intramural ureter is compressed, preventing the reflex. In primary vesicoureteric reflux, there is congenital shortening of the intramural ureter, while in secondary vesicoureteric reflux, increased bladder pressure from obstruction or neurogenic dysfunction overwhelms the normal anti-reflex mechanism. Classification of vesicoureteric reflux, primarily classified into two types, primary reflux and secondary reflux. Primary reflux occurs mainly due to intrinsic defect at the uretrovesical junction, while secondary vesicoureteric reflux can occur due to bladder outlet obstruction, posterior urethral valve, neurogenic bladder, or dysfunctional voiding. Causes of primary vesicoureteric reflux, mainly there is congenital incompetence of the uretrovesical junction in the absence of bladder outlet obstruction or neurogenic dysfunction. There is embryologically there is abnormal lateral displacement of the ureteric bud and leading to short intravesical ureter, and it can be often bilateral. While causes of secondary vesicoureteric reflux can include bladder outlet obstruction due to posterior urethral valves, common anomaly in boys, and can be secondly due to urethral stricture. Secondly, neurogenic bladder can also lead to secondary vesicoureteric reflux. Causes of neurogenic bladder can include spina bifida, spinal cord injury, and thirdly, dysfunctional voiding, bladder bowel dysfunction, chronic constipation, ureterocele or anatomical anomalies can also lead to secondary vesicoureteric reflux. And this is the international grading system of vesicoureteric reflux, which classifies reflux from type 1 to type 5. Based on radiological findings, higher grades correlates with increased risk of renal damage. As you can see, grade 1 reflux only into non-dilated ureter, grade 2 reflux into the pelvis and calyces without dilatation, grade 3 mild to moderate dilation of the ureter, renal pelvis and calyces with minimal blunting of fornices. Grade 4 moderate ureteral tortuosity and dilation of the pelvis and calyces, and grade 5 is gross dilation of the ureter, pelvis and calyces, that is loss of pupillary impressions and ureteral tortuosity. Clinical presentation. Most children present after febrile UTIs in severe or bilateral cases. Progressive renal scarring may lead to hypertension and proteinuria later in life. Complications. The most serious complication is reflux nephropathy. Renal scarring occurs due to recurrent infections and high pressure reflux, eventually leading to chronic kidney disease. Ultrasound is used initially to detect hydronephrosis. The gold standard for diagnosing vesicoureteric reflux is the voiding cystourethrogram, also known as micturating cystourethrogram, which directly visualizes reflux and allows grading. DMSA renal scan is used to assess renal scarring. Voiding cystourethrogram involves filling the bladder with contrast and capturing fluoroscopic images. During voiding, it confirms the diagnosis and provides reflux grading. As you can see in this picture, this is the image of voiding cystourethrogram. You can see the type of reflux on right side of this image. You can see there is significant tortuosity on the right side, and also mild to moderate dilatation on the left side. You can see the grade 3 and grade 4 reflex in this image, and this picture is showing the tortuosity of the ureter. As you can see, this is grade 4 vesicoureteric reflux. Management overviews. Management depends on age, grade, infection history, and renal involvement. Lower grades often resolve spontaneously, while higher grades may require surgical correction. Low grade reflux can be managed conservatively. Prophylactic antibiotics reduces risk of UTIs while waiting for spontaneous resolution, which commonly occurs with growth. Endoscopic injection of bulking agents beneath the ureteric orifice increases coaptation and prevents the reflux. It is less invasive than open surgery with success rate of 70 to 90%. Surgical reimplantation creates a new, longer submucosal tunnel. It remains the gold standard for high-grade reflux or failed conservative therapy. What are the principles of surgical management? Here, our goal is to create an adequate submucosal tunnel and achieve length to diameter ratio more than or equal to 5:1 and establish a tension-free, well-vascularized ureter by restoring a competent anti-reflux mechanism. What are the indications of surgery in vesicoureteric reflux? High-grade reflux, grade 4 to 5, breakthrough UTIs, progressive renal scarring, and poor compliance. Prognosis. Grade 1 and 2 often resolves with age. High-grade reflux carries greater risk of renal damage and requires close monitoring. Special considerations. Secondary causes must always be ruled out. In boys with bilateral reflux, posterior urethral valves should be suspected. Key takeaways. The key goal in managing vesicoureteric reflux is preventing renal damage. Early diagnosis and appropriate interventions are necessary. Widening cystourethrogram is the diagnostic gold standard, and so, in short, we have to prevent early renal damage by managing the vesicoureteric reflux. Thanks a lot for listening to this lecture. Hope to see you in upcoming lectures. Take care till that time. Wish you all very best of luck.